but what he just said was he's having a little bit of discomfort. So can you get it up any higher? Is that more painful as you come up? Okay. And now he's arching a little bit. He's showing you a little bit lumbar lordosis as he does that. Now bring the arms down slowly and stop right there. So right here, his scapula is way out here. This scapula is here. So he can't control the position as well as we would like. Okay, and now bring your arms down. And now let's see if, let me rotate you about 45 degrees this way. And what I'm going to do, the scapular, so now I know that he doesn't have a limitation of motion, but he has some discomfort as he comes up, and I wanted to see, can I eliminate that? So the scapular assistance test is you're holding the scapula here, and all I'm going to do is help his arm come. And I'm not going to do it in abduction because he didn't have symptoms in abduction. His symptoms were in forward flexion. So go ahead and bring your arm forward and up and overhead. Is that any more comfortable?
My left arm.
Jeez. Okay. Let me go this way. Bring your arm forward, up and overhead. And now come down. Any change? I'm sorry?
Kind of hurts when I'm coming down.
Okay. No, so that doesn't change it at all. Was it hurting going up before?
No. Just when I come down.
Okay. So let's see if we can make more of a change. Bring your arm forward, up and overhead. Is that okay? Now bring it down. Okay there?
Yeah.
So we can change the discomfort by positioning his scapula. So now let's look at his rotator cuff. Giovanni, tell me what's happening with his scapula as I bring your arms to your side and bring your arms out, push out. Any winging going on there?
No. Just on the left side. On the left side, just.
Okay. And right there. And now push out. Okay. So some weakness of his external rotators. I tend to test for teres minor here, infraspinatus here, and then we'll come up this way. Thumbs up. And don't let me push you down. Okay. One more time. Okay, so there's clearly some weakness there. Now, the way I would test him is have him bring his shoulder blades back to there. And let me bring you up. Bend your elbows first and out here. And is he okay position-wise? I believe so. Okay, and now wait, I want you right there. Same test. Push out. So I can clearly improve his rotator cuff strength. And now here. Don't let me push you down. Hold your shoulder blades back. There you go. And push up. Okay, so so his scapular retraction test, his scapular assistance test are positive, so I know he's got a scapular dysfunction. Okay? And then do you do anything else standing up?
At this point, do you think that the scapular dysfunction is the cause or is the consequence of this disease? At this point, do you think that the scapular thoracic dysfunction is the cause or is the consequence of the disease?
I think it's the cause. And most of the time in throwers it is. Okay? And so let me bring you to here, and we'll skip the 90-degree, bend your elbow, and bring the scapula forward and hold it there. Okay, good strength of his serratus anterior on this side, and here, bend your elbow. Let me bring you up a little bit.
You can go when you're talking.
He's starting to drift a little bit. So that's it. That's his serratus anterior. So that's where most of it's happening. Okay. So he's got some dyskinesis on both sides. He's actually got a little bit more lateral translation on this side. He's got a little bit of lumbopelvic weakness, not very much. So I see this really as a scapulothoracic problem, and the therapist will address the kinetic chain, but I don't think they have a whole lot of work to do from here down. I think for him it's more the training up here. And then the rest of my exam, I'd want to look at what his motion is like. Let me have you lie down on your back, head up this way, and slide over towards me. And I'll test his other side first, just to get an idea what his normal motion is. He's got more than 90 degrees, the table's in the way, but more than 90 degrees of external rotation, and his internal rotation with his scapula fixed is about 45 degrees. He's a little bit limited in this position. And on this side, on his dominant side, he really doesn't have excessive external rotation, as you would expect in a thrower. And then, let me see if I can do this and stay out of the way. His internal rotation in this position is that. So he's got maybe 45 degrees on the right, which is a little bit of limitation. He's got about, I don't know, 10, 15 degrees at the most on the left. So he clearly has GERD. And so now the question for him is the GERD causing his scapulothoracic problem, or is the scapulothoracic problem causing the GERD?
Is there a question? When you see a GERD like this one, do you think it's a capsular contractor, is a muscle contractor for thixotrophy, or is it because sometimes these throwers have much more retroversion, so it's a bony problem?
I don't think it's a bony problem. I don't know if it's capsule or muscle until I do some other tests and until the physical therapist has some time with him. And the people that are the GERD stretch responders of Craig Morgan, I think were not capsular problems. Because if you look at that big, thick capsule, I don't think there's any way you can stretch that out. So I think the GERD responders are the people that have an extra articular problem, and it's muscular. And it's tight external rotators. But the thing, I want to try to do something with him to see if I can make a change in that. Just let your arm go. And if I'm going to try just pushing his humeral head down and see, does that make a change, which will tell me that it's not capsular. And I'm still holding it down, and I've really corrected his GERD just by manipulating his humerus in the glenoid. So I know that this is, to me, it's a muscle problem that he'd respond very, very quickly. And then I look at how tight are their lats, and the way I test that is you center the humeral head in the glenoid, bring the arm up, and see. Let me just move the pillow for just a moment, Nathan. Okay, is that okay for you? Yeah. So I'm going to test to see his lats, his teres major, and his serratus anterior tightness in this position, because if I hold his scapula, that's pretty uncomfortable, isn't it? He's pretty tight up here, because that you should be able to, with a flexible lat, you should be able to take the arm and put it down on the table. He can't go there. So you want to make sure that you're not cheating, because there he looks great. But if you put the humeral head where it belongs, then that's it for his lats.
Can you check on the contralateral side?
I will in just a sec. And then if you push that even farther, if you bring them out and they come up farther, that's an indication of teres major tightness. So he's got both. And then if I keep him here, and bring him up, just relax your arm, his whole scapula comes up. Here's his scapula that I can put my hand on. And if I can do that, and you see this in swimmers very, very commonly, pitchers and rock climbers for some reason, that's an indication of serratus anterior tightness. So he's got a lot of soft tissue restrictions that have to be worked on. Let me bring you to the other side for a moment. Excuse me. It's allergy season. Okay. There you go. So on this side, here's what he's got for lats. So clearly he's got much more flexibility. If I bring his teres major out, if I test his teres major, there's no change. So that's okay. And his scapula is not really, his scapula is coming out about that far. So this to me is, you can come and sit up, is a muscle imbalance problem that I think would respond very well to physical therapy. And then for the other parts of my exam in throwers that I didn't talk about is looking at instability. I do that in lateral decubitus position. I'll do anterior and posterior apprehension and apprehension suppression, but then my exam for instability is in the lateral decubitus position. So lie on your left side. Slide down a little bit.